Okay. We're going to try to do some audience polling. I'm going to be talking about addiction in the South. I'm an Alabamian, and I trained in Boston and came back to Alabama. And both Southern healthcare is really near and dear to my heart, and now addiction care is really near and dear to my heart. So we're going to start, and I'm going to just kind of introduce where we're headed. I have no disclosures. Our learning objectives today, first thing we're going to talk about is identifying the impact of substance use on morbidity and mortality, specifically in the South. We'll then recognize addiction as a treatable medical disease, really nicely laid out by Dr. Lambert, really highlights some current gaps in prevention and treatment efforts for opioid use disorder, specifically in the South. And then lastly, hope to empower you with some concrete actions to improve opioid use disorder care in your practices, no matter what type of physician or healthcare professional you are. So I'm going to have you tell me a little bit about yourself. You should be able to use either a text, joining by the web, or the QR code that I had up there initially. If you didn't get the QR code initially, it's up there, and I can go back a few slides. If you guys will give me a thumbs up if you get in. I see 0 surveys completed yet, but we'll give you guys a few minutes.
You can go back to the slide.
Yeah, certainly. Should pop up and ask for like just the name it's going to identify. You can just use your first name. And if it doesn't work, we'll just do a show of hands. Excellent. All right, should prompt you for some questions now. This is really just for us to get to know each other a little bit and get to know a little bit about you before I begin. As you guys are finishing, I'm from Muscle Shoals, Alabama. I practice now at UAB, and like Dr. Lambert, I primarily do addiction and consult medicine in the hospital, but I'm a primary care doctor in heart and internist by training, and still really love general medicine, but predominantly do addiction medicine now. All right, I'm going to give you guys one more minute, and then we're going to be done. All right, not everyone's going to get there. We're going to move on with the surveys that are completed. You get to know each other a little bit. So this is where we're all from all over the Southeast, from Maryland, right around the Mason-Dixon line, all over to Texas. I see a lot of APPs in the audience. Thank you guys for coming. A nurse, some physicians, and some other folks. Thanks for joining us today. And have a big contingency of family medicine docs or family medicine practitioners, nurses, and then we have some subspecialties, internal medicine as well. Mostly practicing outpatient care, fewer inpatient care, and some from others. I'm hoping that no matter what you answer, that you'll find something useful and that you can take back to your practice and to your communities. And then the last question was, have you ever prescribed buprenorphine? The majority have not. And some of you cannot prescribe buprenorphine because you don't have a DEA. But we'll be going over how this is becoming
more standard of care for opioid use disorder treatment and how you can prescribe buprenorphine and when you may should do so. So we'll start with our first learning objective now, really identifying the impact of substance use on morbidity and mortality in the South. So we're all aware of the addiction overdose crisis in the U.S. And really thinking about how does this burden really fall in the South compared to other diseases. And I really want to use my home state as an example of how this is hitting, but this is very applicable to all of the states that you're coming from. So first off, this is looking at 1990 compared to 2019, and you can see that contributors to death, that substance use is the 8th leading cause of mortality in Alabama. It was the 14th leading cause, and it went up to 8 in 2019 from 1990. It's the 5th leading cause of morbidity, so not direct deaths, but morbidity and associated with substance use. Again, going from 14th up to 5th place from 1990 to 2019. If we focus, that was the whole population, all adults. If we specifically look at patients from 15 to 49, substance use is the #1 contributor to both morbidity and mortality in Alabama. Ranking 9 in 1990 and now #1. And so this is why it's touching all of our patients. It doesn't matter if you practice addiction medicine or not, it's affecting your patients. And so how does it actually contribute to morbidity and mortality? Substance use primarily contributes as a risk factor for other diseases. And I'm really thankful that Dr. Lambert kind of laid out alcohol and really showing the significant impact of alcohol use on both healthcare spending and morbidity and mortality among our patients. We'd be remiss if I didn't mention tobacco, and those are still the leading contributors to substance use related deaths in the U.S. So what do we mean when we say substance use disorder? Dr. Lambert went over the DSM-5, but really simply, when we say substance use, we're focusing on this huge triangle that encompasses unhealthy use, potentially not a substance use disorder, all the way up to what was traditionally referred to as alcoholism or alcohol dependence, which is now what we refer to as alcohol use disorder, this loss of control and continued use despite negative consequences. And so if we really focus in on that top part of the triangle, what is addiction and why do we call it a chronic medical disease? So I'd like to start with the American Society of Addiction, how they actually define addiction. Really simply, continued and compulsive use despite consequences. And so this is directly from ASAM. People with addiction to use substances are engaged in behaviors that become compulsive and often continue despite harmful consequences. But this is only one part of the definition. And if we look further, this is the whole definition. And it starts with that it's a treatable chronic medical disease. It involves chronic brain circuits, genetics, environment, and individual life experience. I think we sometimes take a reductionist point of view and really kind of boil addiction down to a simple choice. And I think it's much more complex than that. ASAM really nicely captures this with this definition. And I think one thing that you need to realize is that it's really, really treatable and that we can help our patients, even though sometimes it doesn't feel that way. The DSM-5 criteria is how we diagnose a substance use disorder. The DSM-5 can be applied to any substance. It's 11 criteria, and a patient has to meet 2 or more, and those 2 can't just be tolerance and withdrawal. So it can't just be dependence alone. So if we have a patient in their own hydrocodone that we're prescribing, they may have tolerance, they may have withdrawal, but if they don't have another of these criteria, they're not truly going to have a substance use disorder or an opioid use disorder in that case. And I like to boil it down to the 3 C's: cravings, loss of control, and consequences. And to really kind of simplify it, I'm not a psychiatrist by training. I didn't use the DSM-5 when I was in residency, but now I use DSM-5 criteria for substance use disorder nearly every day. But if you really just want to boil it down to these cravings, loss of control, and continued use despite negative consequences, that's really that highlights the definition of addiction. Really going back to this chronic disease model, that it's neural reward systems are hijacked in addiction. And we can see the different parts of the brain that are involved in addiction here. I think a lot of times we kind of think about the euphoria and the binge intoxication stage that's shown here, that's captured in the basal ganglia, but just as important, and perhaps more so important, is the withdrawal and the negative affect that's kind of seed of fear, the amygdala. And so remembering that all these things contribute, and that really patients are just trying to feel normal. Sometimes they're way beyond trying to get euphoria. They're just trying to feel a normal sense of normalcy and try to avoid withdrawal. To further capture this, it not only hijacks the brain. When you're using substances, it actually makes permanent changes to the brain that are reversible, but that last well beyond the substance use. This is a functional MRI model of looking at, on the left there is a patient that did not use cocaine, and then on the right we have patients that use cocaine daily, and then shows months after use. You can see in a healthy subject that we have this sort of red highlighting where the dopamine receptors are, and you can see that there's loss of that even after cocaine is discontinued. So 1 month, and again in 4 months, you see a little bit of return, but not even back to normal. Really, that brain disease can heal, but it does take time. Again, this is a different functional MRI, but it's really looking at methamphetamine use, and just wanted to show that on the left we see a control without methamphetamine use, and then the 2 patients with methamphetamine use disorder. It takes nearly 14 months to regain some of that, those dopamine receptors back to normal. Now that we've kind of thought about it as a chronic disease and one that affects the brain somewhat for a very long time, even after substance use, I'd like to shift now to how we're treating this disease in the South. We saw earlier that substance use predominantly contributed to premature death as a risk factor. But what is the toll from the addiction itself? If we look at substance use disorders and the direct effects from substance use disorders, we see that alcohol leads all the others. And right after that, we see that opioids of the illicit drugs is the next contributor to premature death. I'm going to focus on opioid use disorder. Number one, both Dr. Lambert did an excellent job going over alcohol use disorder. But specifically called opioid use disorder, our prescribing practices greatly impacted this substance use disorder, mainly more so perhaps than any other. Opioid use disorder impacts patient care in our clinic, in our hospital. And lastly, we have very effective medications. So I would argue more effective than the medication for alcohol use disorder for alcohol use than opioid use disorder. To really understand treating opioid use disorder, we have to really understand how the overdose crisis got here. Many of you have probably seen this graph of increasing overdose deaths over the last 10 to 20, now 30 years. The first wave, really in the 90s, began with prescription opioid overdose deaths. That's the light purple line that you see that is beginning to increase in the 90s. And so our first efforts were really targeting prescription opioids. And getting to one of our first disparities, the South has really lagged at turning the tide on this first wave of the overdose crisis. You can see this is opioid prescribing rates in 2010. It's going to go through subsequent years. You can see a slow decrease in opioid prescribing over time, but you can see that the South lagged behind other states. I'll take a little more. My home state of Alabama has been number one in opioid prescribing for quite a while. So we've made progress here, but the question that came out earlier was, is all our efforts on opioid prescribing really reversing this crisis of overdoses? Because we started combating the overdose crisis by really just targeting opioid prescribing. And did that really result in actual outcomes that reversing the crisis? And what disparities were brewing as we tried to crack down on opioid prescribing? What were the consequences of that we didn't intend? I'd like to kind of think about opioid prescribing and point out some of the disparities initially in opioid prescribing and how that played into the epidemiology of the opioid crisis. In the first wave of the overdose crisis, white patients received opioid prescriptions more often after pain-related ED visits. So you see here the top line, you're coming in to the ED with a pain-related visit that are prescribed opioids, the percentage of patients, and then we see non-white patients are prescribed opioids at a less rate. Some discrepancies and disparities in opioid prescribing for pain. And so you may ask, maybe these patients of different ethnicities reported pain differently. But even when controlling for those, so we see both in an earlier cohort and a later cohort at the same, we look at the same pain reporting, that there was still a disparity there. And so this was a real disparity in how we prescribed. And just something I want to put a pin in and really show how it played out in the overdose crisis. Again, racial inequality in opioid prescribing has persisted. So I showed earlier data from the early 2010s. Now we look at data from 2016, 2017. Each of these circles is a different healthcare system, and it's looking at the dashed line. If it's above the dashed line, white patients were more likely to receive opioids than black patients. In over 90% of health systems. And this included 300 health systems. And that was both for short-term opioid prescriptions and longer-term opioid prescriptions. And this is correlative, but this is perhaps in part due to this differential prescribing, that white patients became the face of the opioid epidemic. And you can see here that in terms of overdose deaths, that white patients had a higher rate of overdose death for a long time. And that the face of the opioid overdose became white patients. I'd like to reflect on the differences in our response to this modern opioid crisis as a white problem to the heroin epidemic of the 60s and 70s that really affected black young men, and how we responded. Rather than treating a disease, we really cracked down and produced criminal justice reform that really led to only mass incarceration and didn't really improve our patients' care. I do think we should have some moral unease in how we responded differently to the modern crisis and how we've responded differently in the past. But how can we move forward? How have these preventive efforts of reducing opioid prescribing over the last 10 or more years of the modern epidemic really paid off? They really haven't. So reductions in opioid prescribing, you see on the bottom on the purple line, just as we saw in that heat map, opioid prescriptions have decreased over the last 10 years, but overdose deaths have continued to climb. And why is that? It's because the overdose crisis has evolved. So we saw the first wave of prescription overdose deaths, but then we see the orange line, which is heroin, really starting to pick up in 2010. And then from 2014-15, the synthetic opioids have really dominated the market, specifically fentanyl, now the number one contributor to overdose deaths in the country. And for a long time, we really thought of this as a white problem, as I kind of reflected earlier. But for the first time in 2020, black overdose death rates surpassed white overdose death rates. And so fentanyl is killing all of our patients, so no matter what their skin color. And I think it's time that we have more equitable care and really think about this as we move forward, some of the mistakes we've made in the past. You can also see other communities of color that are really affected. The American Indian population has had quite high overdose death rates for a long time. This specifically really reflects on the question, where should we invest our resources? This is looking at standard mortality ratios after certain touch points. And a touch point is defined as a healthcare encounter where one of these things happened and how we can basically reduce an overdose death in the future. This work is done through observational data out of Massachusetts with over 1,000 patients. And it looked at first opioid prescription touch points, and they defined these as health encounters where someone was prescribed high doses of opioids, they were co-prescribed a benzo with an opioid, they were identified as having multiple prescribers at the same time, or using multiple pharmacies. And we can see that compared to patients that did not have one of these touch points, these patients do have higher mortality ratios. And so we should invest some time and some resources at these touch points. However, if we look at addiction touch points where patients have gone beyond just misuse of a substance to actually developing opioid use disorder, we can see that their mortality ratio is significantly higher. Here's a few of the touch points that were looked at. So someone coming in for opioid detox had a 66-fold increase in their death rate compared to the general population. And if we look at someone that's coming in after a non-fatal overdose, their death rate after that non-fatal overdose is over 100 times the general population. So really thinking about how we can invest in these touch points at the bottom, as we continue to focus some efforts on the top. I'm going to take a moment and look at the non-fatal opioid overdoses and how we can really use healthcare resources at these moments to hopefully prevent mortality in the future. At these touch points, we do have medications that save lives. And so this is a different study, and it's looking at months after a patient comes in after a non-fatal overdose. It looked over 12,000 patients coming in after a non-fatal overdose and looked at were they prescribed a medication for opioid use disorder or not. And we had 3 FDA-approved medications for opioid use disorder. You see the 3 here: methadone, buprenorphine, and naltrexone. And this is looking at all-cause mortality after these non-fatal overdoses. And you can see that compared to not being prescribed one of these medications, this reduces all-cause mortality. Unfortunately, only a minority of these patients actually received these treatments. So only 30% of this group of 12,000 people actually received one of these treatments, while 70% were in that line that included no medications. Just to highlight some of the pharmacology of these 3 FDA-approved medications and how they're prescribed and when they can be prescribed. We'll start with methadone. It's a full agonist, a long-acting opioid. You can start it during opioid withdrawal. It has to be dispensed at an opioid treatment program, what we colloquially call a methadone clinic. It can be used in hospitals and can be dispensed there, but in the outpatient setting, it actually has to come through a methadone clinic to be dispensed for opioid use disorder. So it's not something we can incorporate in primary care settings right now. Canada does this a little differently, and I think that we'll probably see methadone change in the future. But for now, it has to be dispensed in the outpatient setting at one of these methadone programs. Buprenorphine is a partial opioid agonist, so I always go over this with patients. It is an opioid. It's a Schedule III opioid. All the other full agonists are Schedule II. And it's a partial agonist, so it binds on the same place as the full agonist does. And it can be started during opioid withdrawal. And previously, it could be prescribed anywhere with the X waiver, but that has changed, and we'll get into that with the new laws. And then lastly, our last medication is extended release naltrexone. So oral naltrexone is approved for alcohol use disorder, but it's not shown to be clearly effective for opioid use disorder. You can use extended release, the intramuscular form, both for alcohol use disorder and opioid use disorder. It is an opioid antagonist, so it's not an opioid, so it blocks the receptor completely. And so you can't start it while someone's withdrawing, or you're just going to make that worse. And so you have to allow that patient to completely come off of opioids. For patients that are opioid dependent, that takes about 7 days for heroin or fentanyl before you can start naltrexone. It could be started in primary care settings and in the hospital setting too. Not all the treatment pathways, when we look at treatment pathways that include medications and treatment pathways that don't include medications, they're not all created equally. So this is a kind of a cluster, but I'll break it down for us. If we look at just patients coming in for detox, and we just detox them from opioids and then we release them back to the community, we can see that it's basically like offering no treatment. So opioid detox alone is not treatment. It is a bridge to treatment, but it's never treatment in of itself. We have to kind of use other things, and the most effective things are medications for opioid use disorder. We see the agonist medications, buprenorphine and methadone, have a higher rate of people continuing without opioid overdose than extended release naltrexone. And why is that? It's because naltrexone is really hard to start, as I mentioned earlier. You have to have the patient completely come off of opioids. And so this was a trial that was looking at naltrexone versus buprenorphine, the XSPOT trial, released in 2017 in Lancet. And if we looked at the per protocol analysis, so the patients that actually started medicines that were on buprenorphine or naltrexone, they did really well, and it did as effective as buprenorphine. But if we actually look at the people that were randomized, we had a huge dropout rate when we looked at Vivitrol or naltrexone. So there's a 28% induction failure with the extended release naltrexone, because it's really hard to get patients through those 6 to 7 to 10 days of opioid withdrawal before you can start it. And so looking back at that data that we looked at before, that data in Massachusetts that we're looking at patients after non-fatal overdoses included periods where patients were on treatment. This data now is looking at patients that have discontinued treatment or have interrupted treatment. And we see that the agonist medications, buprenorphine and methadone, continue to offer protection even when patients have interrupted treatment. And so really suggesting that agonist therapy should be sort of the gold standard. Naltrexone is a very effective medication and can be used for certain patients, but remember that it has a high rate of induction failure, and to really consider that when you're starting treatment. Going back to disparities in the South, looking at specifically opioid use disorder care this time, the need for expanding medications for opioid use disorder access is great. This is data out of the Health and Human Services, and it looked at 3 measures: so drug overdose mortality, non-medical use of opioids, and opioid prescribing, just to look at the needs for opioid use disorder care using these surrogates. And you can see if the light green is 2 out of 3 markers were high in these area, and if it's the dark green, they were in the 80% or more index for all counties across the country. And we can see here that in the South we have a lot of the high need and highest need communities across the U.S. So we kind of talked about opioid prescribing, and now we kind of recognize that we need a shift to really treating opioid use disorder. And so as we make this shift, have we learned from these past disparities in addiction to reconcile some of the current ones that we're currently facing? We haven't. So we have increased buprenorphine prescribing. We recognize that it works. And you can see here that we recognize that it works. And in the early periods when overdoses were affecting white patients more than black patients, we understandably maybe have prescribed more buprenorphine to white patients. However, looking at more recent data, this is data the late 2000s, you can see here the left is white patients, the right is black patients, and you can see that most black patients did not receive medications for opioid use disorder, whereas they were offered to nearly 50% of white patients. And so seeing disparities even now, again, 2020, we saw the black overdose death rate surpass that of the white overdose death rate. We still have disparities in addiction care, just like we had disparities in pain care earlier. And so we haven't learned yet, but I'm hopeful. And one way to correct disparities is to just point them out first. We can't treat disparities if we don't know about them. So one disparity that I wanted to bring to everyone's attention. Lastly, now that we've talked about addiction care, a little bit about the evolution of the opioid overdose crisis, I want to kind of go back to that we have a range of providers here in the audience. Some of you are in primary care settings and community clinics. Some of you are not. And I just want to say that you all take care of patients with opioid use disorder. So we're going to turn to some concrete actions that hopefully all of you can start employing in your practice. I don't expect all of you to start prescribing buprenorphine and treating opioid use disorder in your daily practice, but I think there are small ways that you can contribute to the national crisis. First off, I'd like to show some data about training programs. And so though we may not all treat opioid use disorder, we, again, all care for patients with opioid use disorder. And we're going to start with a case. This is a 57-year-old man with hypertension, diabetes, opioid use disorder that's been in remission. He's on buprenorphine naloxone, or brand name Suboxone, and he presented with chest pain and found to have a type 1 STEMI. This is his hospital course. So he had a trope that was elevated. He had SE depressions and inferior leads there. His UDS was appropriately positive for the prescribed buprenorphine. In the PDMP, you check it, and he has regular prescriptions for the past 2+ years that you look back. It's the same provider, same pharmacy, no early fills. His prescriptions are for 1-month durations. And so he is treated for his non-opioid use disorder related a complication, right? This is something that could happen to any patient. It can happen to a patient with or without opioid use disorder. He had a drug-eluting stent placed to his right coronary. I just want to show you kind of his progress and his recovery that was all the work that he had done before this. His substance use history included some opioid pills that were prescribed to him in his early 40s for some back pain. This escalated to illicit pill use by 45, and he started buprenorphine at 47, and he's been sober from illicit opioids for the past 10 years. He does smoke and likely contributing to his risk for coronary disease, but no alcohol use and no other illicit drug use. You're getting ready to, as a hospital provider, discharge this patient. It's the weekend. You've continued his buprenorphine throughout his stay. And unfortunately, he missed his provider appointment for his substance use care, and he is out of medications, and it's the weekend. And so now I'd like to ask what you would do in this situation. So you should be able to use the same window as before. Again, you also can join by text. The instructions are up there. If it doesn't work, we will, let's see if I can get it. Give you guys, see 7, 8, so we'll get up to 20 and then see how y'all responded. So the options, again, it's the weekend. He can't get in with his provider. So the option is to send in a 5-day prescription for buprenorphine at his dose that you saw in the PDMP, the prescription data monitoring program. Or you say, I don't have an X waiver, can't prescribe buprenorphine, and tell them just to follow up on Monday. All right, I'm gonna go ahead. Look at the responses together. And so a lot of you said you had offered the prescription, and some of you were maybe more honest and said you don't have an X waiver. This used to be what everyone said. I'm an addiction consult provider, so I work with a lot of hospital medicine groups. I work with cardiologists. We work with surgeons. And this used to be what everyone said. So I don't have an X waiver. I can't prescribe buprenorphine. We can't use that excuse anymore. So just this year, it passed last year and is now effective. The MAT Act, the Mainstreaming Addiction Treatment Act, eliminated the X waiver. So the X waiver was a previous waiver that you had in your DEA that allowed you to prescribe buprenorphine. You no longer need that X waiver anymore. And the Medication Access and Training Expansion Act of 2020, the MATE Act, empowers all DEA registered providers to prescribe buprenorphine. This varies state by state. Our first speaker went over some nuances to prescribing controlled substances. Buprenorphine is still a controlled substances, but the intent of this law is if you can prescribe oxycodone or you can prescribe a fentanyl patch, you should be able to prescribe buprenorphine. We can contribute to opioid use disorder. We should be able to treat opioid use disorder. And so I just want to empower you. These new laws, they do now require that at the next time you renew your DEA or that you initially apply for a DEA, you have to attest to 8 hours of training. These 4 hours here can count toward your training. And you can, if you're not board certified in addiction, you just have to have these 8 hours. Cumulatively, they can be at any time over the past. In past X waiver, so if you used to have an X waiver, it counts. If you didn't have an X waiver before that it was eliminated, any past trainings fulfilling the topics above, specifically around opioid use disorder, but any substance use disorder care, in all these groups, and specifically the ACCME credits Southern Medical Association, and you get CME through coming to here, and so this counts toward that requirement. And so the next time you'll have to attest to that when you register for your DEA. Going back to what the data shows traditionally, again, even though we're all from different specialties, we all care for patients with opioid use disorder. This was looking at residency programs of internal, family, and psychiatry, and it showed that over 70% of programs identified as having patients with opioid use disorder. But you can see here traditionally, and this is data from 2018, a little before 2018, that traditionally psychiatry has led the way in terms of prescribing opioid use disorder medications and training the residents in that. So we have work to do. I will say I'm an internist, I'm not a psychiatrist. Some people mistake that, but I train and I love primary care, and we all need to be involved in the addiction solution. Specifically now, I'm going back to the requirements that were laid out. Graduate medical programs, so residency programs across, it doesn't matter what, this is a common core requirement, so it doesn't matter what specialty. So any group that is, any residency program accredited by the ACGME, so that could be surgery, it could be OB, it could be internal medicine, now have to incorporate some training toward substance use care and safe opioid prescribing, such that their graduates from the past 5 years no longer have to get these 8 hours that we all have to. So in the future, this will just be part of medical training, and hopefully we won't see these disparities. So the next case, what happens when a patient with opioid use disorder may need temporary opioid, and by opioid here I mean full agonist, so a traditional full agonist like hydrocodone or oxycodone, they may actually need opioid therapy. And so this is the next question, or next case. We have a 34-year-old woman with severe opioid use disorder. She's in early recovery, so not 10 years that our last patient was. She has chronic hepatitis C, and she's hospitalized for acute cholecystitis. She presented kind of in a classic way with fever, right upper quadrant pain, a leukocytosis. Her lipase was normal, wasn't pregnant, and she had a right upper quadrant ultrasound that had a positive sonographic Murphy sign and some gallstones. Her EDS was positive for buprenorphine. It was also positive for opioids. However, the emergency room administered some morphine prior to her getting this urine sample collected. It's negative for fentanyl, and specifically this is important because fentanyl was her previous drug that she was using before she was in recovery. Again, to highlight some of her journey, she was started opioid pill use recreationally in college, which then led to insufflation or intranasal heroin use at 27, then IV heroin use at 28, to IV fentanyl use at 32, and last 2 months ago was her last fentanyl use, and she was started on buprenorphine 2 months ago, and she's currently on a dose of 24 milligrams. She completed a 30-day residential addiction program before, as she was getting started on buprenorphine, and now she's going and returning, living back with her parents. So back again, you're caring for a patient that, again, has opioid use disorder, but this is a hospitalization that, opioid use disorder is a comorbidity, but it's not the main reason she's there. She expresses concern around being prescribed opioids, but she's fearful about postoperative pain. And she's scheduled to have her gallbladder removed. And this is, what do you decide to do? So a little harder than last time, asking what to do while you're in the hospital caring for this patient. You may be the surgeon that's kind of taking over care, or you may be the hospitalist co-managing. Since we're not getting a lot, I may just do a show of hands here where everyone can participate. So who would choose A? Just show of hands. Continue the buprenorphine at her home dose of 24 and just offer no opioids, like no morphine or anything. Who would do that? Show of hands. Okay, no takers. Option B is to stop the buprenorphine. So stop her home medication. Order opioids like you normally would do for any other person going a lac chole. Got a few takers in the back, a few there. Option C was to continue the buprenorphine at her home dose again.
order full agonists like hydrocodone, morphine, oxycodone, but may actually use slightly higher doses. Who would do that? Okay. And the last is lower the dose, space it out a little bit, and order some full agonists, again, maybe at slightly higher doses. Okay. See a lot of responses. I will say there's not clear consensus here. I will give you, this is my philosophy, but a lot of the addiction community would probably endorse what I'm saying, but there's still debate in the addiction literature around this. But I do want to kind of give you some rationale of best practices around pain management, specifically acute pain management when someone's on buprenorphine for opioid use disorder. So I would say don't stop the buprenorphine. That is a medicine that is life-saving. It offers stability, and she's early in her recovery. And the concern there, though, is that it's a partial agonist, and the reason we use it for fentanyl use disorder is it blocks out fentanyl. It binds really tightly to that receptor. It has one of the highest binding affinities of any opioid, and so it binds really tightly, and it blocks opioids out. And so it is very difficult to control a patient's acute pain with full opioid agonists while buprenorphine is at really high levels. And this is data. This curve is just based on one study. This curve is not perfect. It's just based on one study. But you can see the cumulative daily dose of buprenorphine and the percentage of receptors that are occupied. And you can see that at 16 milligrams, nearly 80% of receptors are occupied. And she's at 24. So she's up above 80% of her receptors that are occupied. And so she has not very much room for full agonist to work. And so sort of my approach, and others' approaches as well in the addiction world and in the anesthesia world now, is to really lower the dose. Ideally, you would do this a few days in advance, if possible, because buprenorphine has a long half-life, and it's going to take some time to come down to a level like this. So you should do this as soon as she's admitted, really, to make more room for full agonist to work. She's not going to get by on just her buprenorphine. That's just making her feel normal. It's not offering any analgesia for this patient in particular, especially for the acute pain. Buprenorphine can be used for chronic pain. This is a case of acute pain, though, and she's on a dose of buprenorphine, so it's really not going to do anything for her acute pain. I do recommend splitting up the dose. The analgesic effect of buprenorphine is 6 to 8 hours. And so by splitting up the dose, we get a little bit of pain control from the buprenorphine, but this is a case where you're going to need some full agonists, and we're going to have a conversation, a tough conversation with the patient, and you may not have an addiction provider there to offer that education. You may be the one that's doing it. So this is, again, my approach, many other addiction providers' approach, and the rationale for that approach. The other reason for not stopping buprenorphine is difficult to start when you have full agonists in place because they can send people into withdrawal if you have full agonists in place. It doesn't work the other way around. So if someone is on buprenorphine and they use a full agonist, it doesn't send them into withdrawal. But if we're starting buprenorphine too early in a patient that's using heroin, for instance, it will kick out the heroin out of the system because it's binding really tightly and send them into withdrawal. By letting the buprenorphine stay in the system, you're avoiding that whole ordeal. The last case is really going over that opioid use disorder affects many patients, some even without opioid use disorder. So this case is a 49-year-old woman. She has hypertension, hypothyroidism, depression, and she's coming in for a routine primary care visit. These are her medications: amlodipine, levothyroxine, fluoxetine. Again, no mention of opioid use disorder here. Her blood pressure is at goal. You're going over. She doesn't have any concerns that she states initially. Her TSH is within goal too. You ask about her mood since she has struggled with depression and on fluoxetine. She says she's feeling all right, but just a little stressed. And you ask, tell me more. And so this is her substance use history. She has no smoking. She drinks a glass of wine twice a week. Really no heavy drinking, no times that she's even drinking 2 or more glasses. She had some marijuana use in college, no other illicit drug use ever. But she had a son that recently overdosed on fentanyl. He was found and resuscitated by his roommate. And this is the 3rd overdose in the past 2 years. He completed a 2-month residential program and is moving back in with his parents. And this is why she's stressed. And so here's some ways you may respond to that. Again, incredibly difficult moment. She just shared something that has a lot of stigma behind it, really sharing about a son who's struggling with addiction. She didn't feel comfortable doing that initially. She didn't come off right off the bat. It took a little bit of time. And so you're here to offer some support. And these are some examples of how you may respond. So I'm just going to read out the responses. So you offer as her provider, it must be incredibly difficult having an addict as a son. We're here if there's anything we can do to support you. Another provider, they may choose another response. I can only imagine how concerned you must be about your son and his battle with addiction. So I hope he never suffers another overdose. Do y'all have a naloxone kit in the house in case of an emergency? You have a lot on you. Let's consider increasing your dose of the fluoxetine. So again, I don't want to say that there's one right answer or one wrong answer, but do want to highlight some things some missteps and hopefully avoid these. So responses. Everyone kind of got the answer I wanted. But to go over why the other responses, there's more we can do, and more we can do for this patient that's not struggling with opioid use disorder, but is affecting her family. This was a slide shown earlier by Dr. Lambert, and really thinking about what we say really matters. And though the term addict is something that patients in recovery will say, I tell trainees that I work with, I work with residents, internal medicine residents, psychiatry residents, medical students, and addict is something that a word that patients in recovery may choose to label themselves with, but they can use whatever word they want, right? They're the ones that have struggled with the disease, but it's up to us as medical professionals to use accurate and clinically less stigmatizing language. And so we would say a patient with opioid use disorder in this case, and rather than like clean time, we would say this person in recovery or that's sober, and really trying to avoid some of these stigmatizing terms. And so that was one thing that came up in the encounter in trying to avoid that with this patient's loved one. And for patients both with opioid use disorder and those without, we always have the opportunity to lower the risk and reduce harm of continued use. This patient's loved one, her son, had 3 overdoses. This is a chronic disease, and so it is, while it's highly treatable, relapse sometimes does happen and is part of that disease sometimes. And it's good to prepare for that, right? We're not hoping for that, but we want to prepare if that happens. So Narcan or naloxone, generic name is an opioid antagonist. It's short-acting. It reverses overdose. It was actually just FDA approved to be over-the-counter. But you can go to Next Distro is a harm reduction website that has links to every state or resources for every state, or at least point you in the right direction of how you can get this. And the other thing, Narcan doesn't do any good if you're using alone. Someone has to use Narcan on this patient's loved one, right? His roommate had to find him. And so if his roommate wasn't there, it didn't matter if he had Narcan or not. He would have died. And so some things we have to do is counseling that you should have a buddy around, like Buddy the Elf. And the other thing we can do is connect patients to, there's a national hotline called the Never Use Alone hotline. This hotline, This American Life is a podcast. If you listen to This American Life, they just did a beautiful story on the Never Use Alone hotline that was exceptionally human and would highly recommend as a mom that was actually the person that was answering calls on this and had a daughter that was struggling with opioid use disorder. So this is a resource you can give to your patients and counsel about. So that's the conclusion of the 3 cases, just to highlight some take-home points. Substance use is the leading cause of morbidity and mortality for patients of 15 to 49. Addiction is a chronic medical disease that's treatable. It involves behavior, but it's not only behavior, right? We wouldn't say diabetes is only about what you eat, right? And so although we should offer behavioral counseling and behavioral interventions, it also requires medical interventions too. Our past responses to substance use and pain are mired in disparities. They are continuing to be mired in disparities. And whether we choose to acknowledge them or not will shape our success or failure in slowing the crisis and preventing future disparities. Lastly, we have opioid use disorder. We have buprenorphine that's now FDA approved. It's been FDA approved since 2002. I'll say that again, 2002, it's been FDA approved. And it's a mortality-reducing treatment. It can be prescribed by all DA providers now under the new MATE Act. You'll need 8 hours the next time you renew or go up for initial renewal. Patients with opioid use disorder in recovery will experience other health problems. They will come to your office whether you're an addiction provider or not. They will come to your hospitals whether you're an addiction provider or not. So even if you're not treating opioid use disorder, you'll treat these other problems, and it's really important to know how destabilizing opioid use disorder during one of these other health conditions could lead to their death, or how you could really support them and lead to their recovery. And lastly, like all of us, patients with opioid use disorder are complex individuals. They have unique experiences, and they have people that care about them deeply, like that mom did. Remember your words matter, remember their lives matter, and ensure that they and their loved ones have naloxone at the least. That's all I have. I have time for questions, and you can also email me.
We really appreciate that, especially the polling. That was pretty neat on polling. I think we'll have to use that in the future. We'll take a couple of questions real quick.
Okay.
Thank you very much. That was excellent, and I love the case studies. In the disparities we see often in situations where someone who has opioid use disorder is incarcerated, and they go through a relatively rapid detox because there's no other essential treatment while they're incarcerated, and they may get some therapy while they're awaiting their discharge. But I am not aware of any correctional facilities that use medical treatment for these patients. Are you aware of any movements within the addiction community to implement the medical treatment for incarcerated former or opioid use disorder?
Sure, I can speak to that. I'll first give a reflection on Massachusetts, where I trained, and then on reflections from where I am in Alabama currently. So in Massachusetts, when I was in training, there was a disparity. There were some places that correctional facilities that did offer medications for opioid use disorder, including agonist therapies, including buprenorphine and methadone, but that was hit or miss. That slowly changed when I was that actually was led by a patient advocacy movement that actually filed a suit against the Department of Corrections in Massachusetts. So it wasn't physician-led, but it was patient-led, and they actually won that suit based on the Americans with Disabilities Act. And so now Massachusetts, and I'm a little bit out of date now, I haven't been practicing in Massachusetts for 3 years, but they were a trial model to expand opioid use disorder medication care in prisons and jails as well. So that was a highlight, mainly led by our patients, unfortunately, not really joined in by us. There were some advocates among the provider community, but it was really patient-driven. And then we look at where I'm practicing now in Alabama, and just to give you an example, I practice in Birmingham, Alabama, and we have 2 jail facilities. We have a county jail and a city jail. The county jail will offer patients buprenorphine detox, so they'll use buprenorphine to actually help taper off, which is more effective than offering something like clonidine, but they won't continue it as evidence-based care, whereas the city jail doesn't offer anything. They'll just offer, some Tylenol, some ibuprofen, and so that there's disparities there. And so I would encourage everyone that's also, you're caring for patients that are incarcerated or detained, and to get to know what your communities do. and then talk to your legislators and community advocate groups, because really it's going to take some change nationwide.
Outstanding. I think we have another question over there.
Hi, so I actually am a formerly incarcerated transition patient provider. So I see patients who are released from prison system in North Carolina. And to speak to your question, North Carolina actually, in 8 counties that have FIT programs, they actually do start Suboxone post-release for patients. The downside is they do have to go to those counties that have a FIT program, but that started about a year ago. So I'm seeing patients now who are released from the prison system and or jail who have started Suboxone while in-house. So that's a good transition.
Thank you for that.